So today, if y'all want if you need to email me about any questions that come up, I love questions because it makes me study. A lot of times I do not know the answer, but I'm a good person at researching things. So feel free to just circle that email address, and you can email me at any time. Now, one of the things, as you know, over the last 5-6 years, if you've been in the education arena and just finished school, you talked a lot about evidence, and I know in our journals for critical care, we've talked about a lot putting the cow out to pasture, because a lot of things we've done have not really been evidence-based. And one of the things as we go through, when I'm presenting different interventions, I always have it related to what the American Heart Association, the American Stroke Association, their recommendations, and also I will have indicated on those recommendations the level, how strong it is. And we really like the level of evidence to be A, data derived from multiple randomized clinical trials. And here at Erlanger right now, we're involved in clinical trials. So this is some of the strongest evidence that you can have as far as interventions for any type of patient as far as different care. Then you have B, it's derived from single randomized trial or non-randomized studies. And sometimes we have expert opinion or case studies. You might not have a large group that you're studying, but you base your care on the outcomes of maybe a few that are expert opinion. And then you have your strength of recommendations also, 1, 2, and 3 class. So you'll see that as we go along. Now, as far as definition of stroke, we know that it's not just the brain, but also whenever you define stroke, you define it as a ischemic event that involves the brain, the retina cell death, or the eye, and the spinal cord. So anything, all of 3 of those have to do with the central nervous system. And it's based on not just the clinical presentation, but also it's based on neuroimaging. Now, sometimes you do have silent infarcts that do not show up clinically. The person may, maybe it's just not been reported or whatever, but if you look at an MRI, you will see where the patient's actually had a stroke. Today we will talk not only about ischemic stroke, which is the broad part that we mainly focus on, but also stroke, of course, involves intracerebral hemorrhage and subarachnoid hemorrhage. So we will differentiate those as we go through. Now, stroke history is very interesting as far as if you look back, even 2,400 years ago, Hippocrates described someone having paralysis. And then in 16 and 20, in the 17th century, there was a Professor Wepfer who first actually looked at what was going on when people had paralysis or presentation of stroke symptoms, and he did autopsies and found that it was a vascular organ. So since then, the pathology has been studied related to the cerebral blood flow as it relates to stroke. Now, as far as world history, it's interesting to note that there's been several presidents that we've had that's had strokes while they've been in office, and it's definitely impacted our world and our own United States as far as the way we have evolved. It was really interesting. I read the other day, one of the things, how many of y'all know, have worked with a patient that had the brainscape procedure here? Several. Well, one of the things it was saying that Ariel Sharon, the Prime Minister of Israel, had a stroke about 2006. If the brainscape had been, if they'd actually had it going like it is and being studied in Israel, it just came out about that time that it might have made a difference as far as his recovery, which, you know, he had that stroke and then was in a coma for several years and died this, I believe, in 2014. So he did not respond well as far as any treatment that they had, but it might have made a difference if the brain's gate, since it was actually developed in Israel, as far as his outcomes. Now, if you look at stroke, I was just reading, and this is really interesting. You can change this. I can't believe I haven't put, it's the 5th leading cause of death. It moved down to 5 to the 5th leading cause of death just this last year in the United States. But still, the numbers of people having stroke has really not decreased. Have y'all noticed us having a lesser number here? It seems like more and more people are coming in, aren't they? But still, every 40 seconds, that part is not decreased at all as far as the number of people actually having strokes. But we're doing better as far as our interventions that prevent them from dying. And also we're doing better as far as preventing disabilities with a lot of patients too. But we still have a huge, huge burden on our economy as far as stroke is concerned. Now, stroke in infants and children. 1 out of 4,000 children will have a stroke in utero. This is probably a preemie. This is probably a baby that is very premature and very fragile. But I was reading just something that came out yesterday, and it was saying that like 10 to 20% of all strokes occurred in children. And this was usually during their first year of life. Okay? So I'm thinking even a preemie, a child that's been in the neonatal for an extended period, those people, those children are at higher risk for having a stroke. In our area here, sickle cell disease that impacts the African American population more than any other group is fairly common. So that would be sickle cell. Of course, it alters your ability, your clotting mechanisms. It causes decreased blood flow to different areas of the brain. And these children in the past have had a high instance of stroke. We're doing better now. Once they're identified as having sickle cell at birth, then by the time they're 2 years old, they start using a transcranial Doppler, just like they do on your patients with aneurysms. And they can see the velocity of the blood, and then at that point provide interventions that can help prevent strokes in those children. So we have made some headway here with sickle cell disease. Another thing is our childhood as far as immunizations. There was, before we started getting varicella immunizations for chickenpox, those children, we had a higher instance of stroke in that group too. And you think, what's chickenpox? That's no big deal. But children did get encephalitis, and they did have strokes related to that. Now, in the same way, I'll just give my little pitch for immunizations. But you've read about people dying of meningitis this year. You have read of them having sequelae from meningitis because they were not immunized. So, you know, you have to weigh the benefit versus the risk overall. And you guys sitting out here today do not remember, because you weren't even born when the polio epidemic and you saw all these crippled people that were on, the lung machines to help them breathe. You don't remember having friends or that die, or children, your own children back in the early 70s, are friends, children of friends that had meningitis. So immunizations do, I think their benefit outweighs any adverse effects that might occur. Now, this is us right here, and as you can see, this is a huge issue here as far as the stroke belt. And we just tend to have more risk factors in this area, and it's amazing. I did hear just last week, and I haven't followed up as far as our statistics in Tennessee, but when you're talking about hypertension, I was told that in Tennessee, we have like a population of like 70 or 80% of our population has hypertension. more so than any other state, or at least probably all these southern states. They probably all have a high instance of hypertension, and the number of intracerebral bleeds because of that is astronomical. And you all see it every day, don't you, when they come in? So these are things we can't do anything about as far as risk factors. They're non-modifiable. But we can look like at the African American race who has a higher incidence and focus on them and help as far as educating them and getting them in, you know, to come in with their symptoms, to use prophylactic as far as high blood pressure, etc. Those things they're risk factors. Gender, women are a little bit higher instance than men as far as stroke, and they also have their own risk factors. Now, age, as we get older, we tend to have more strokes, and they're that 80 plus. People are living to be a lot older, aren't they? How many of y'all have had a patient with a stroke that's been over 80 in the last week or two? Several, okay? And we're a lot of times treating those people really aggressively. I mean, you got some pretty healthy 80-year-olds, but of course you also have some very unhealthy 80-year-olds. Now, African Americans have a risk factor of first ever stroke of almost twice, so that tells you something. Candace and Jill were just showing me the latest data last week for Erlanger. And this to me is astounding, y'all. Last year, we had, I believe, 2,197 strokes or something like that. Let's just say 2,200 strokes. Out of that, over 2,000 strokes, someone guess what percentage did we treat that were African American? What do you think, Adrika? What percentage do you think? 70? Anybody else want to guess? How many of y'all would you say that most of your patients have been African American that you've taken care of last year that had a stroke? Heather, you're doing that, aren't you? I think sometimes we just think about it. They must be because they're at such a high risk. But you know what? 10%. Twice as many African American people have strokes. In this area here in Chattanooga, 1/3 of our population is African American. So what's happening? It's very interesting. It's not just here, it is across the United States if you look at all the stroke data. So when we have these health fairs and things to really focus in different communities and everything, it's very important. And I don't know, it really didn't improve. I mean, by improving, I mean it really didn't show that more African Americans were coming in here last year versus the year before, even though I think Erlanger is doing outreaches, trying to educate and get out in the community. Very interesting. Of course, one of the big things here is they have the highest instance of high blood pressure. And is this genetic, or are this population more salt sensitive or whatever? But there's probably a lot of different things that predisposes the African American folks to have higher blood pressure. So as I said, we cannot really do anything, but we can look at our family history. And if you have a mother, a father, first-degree relatives that have a stroke, then you are going to be at a higher risk also. Now, gender women are very interesting to me. And in fact, I want to have our statistician here to pull all the data in the last year of women that have a stroke like under 40 years of age. How many of y'all have had a patient under 40 years of age that's had a stroke? Yep. Anybody else? Sure. But so 1 in 6 women will die of a stroke. And as far as the number of people that die with breast cancer, it's they're 1 out of 25 that will die with breast cancer versus 1 out of 6 that will die of a stroke. So we need to have the White House to go red for women, okay? I know that they go pink for women during the, whenever they're focusing on breast cancer, but really and truly, heart disease and stroke is what's killing us. Pregnancy and childbirth. Very interesting. If a person has preeclampsia, and that would be if you had high blood pressure, if you were spilling albumin during your pregnancy, that's preeclampsia. Of course, if you have eclampsia, then you're going to have seizure, have extremely high blood pressure, and those people that are eclamptic definitely at our high risk of having a stroke during delivery or etc. Okay, a lot of times they are induced and delivered early to prevent some of this. But during that period and afterwards, down through their lifetime, anyone that's preeclamptic or has eclampsia, you just need to be guarded about your own health and taking care of yourself and making sure you take care of your blood pressure. And if you continue to run high blood pressure after that, then that definitely will predispose you to stroke. Depression is a big deal. There is a correlation between depression and stroke, and there's been more and more studies on this as we go along, so you'll probably hear more about that. I'll talk about birth control pills in a little bit, but there is of course, the Women's Health Study did show a small correlation between people that took estrogen post-menopause and stroke, so there was some relationship there. Low birth weight. This is another reason when you see all that area in the South where we have stroke is it may be they've seen a correlation between low birth weight and stroke. So an infant that's a preemie that weighs under 5.5 pounds as compared to a larger baby, those children down the road, if you study, they did this big study in South Carolina, it was double those, as far as their stroke was double those that were of larger babies. So this is another thing we can work on from that end. I mean, it's, to me, in the United States, if you look at us as a whole, the number of, low birth weight babies, it's just amazing to me that in this country that we have more than any other country in the world, and we still have these babies born. Now, about 2008, this is, some of y'all know Tina, this one of our students that had a stroke. And Tina has taught me so much because she had a stroke while she was in school, and I'll talk about, I actually had a little stroke support group of students that have had strokes while they've been at Chattanooga State. And all of them had strokes under 40 years of age, and for different reasons. But Tina has taught me a lot because I have seen what happened to her, over the years, and what happens with stroke patients when you have a new brain. And a lot of you all may be like me. I don't know. I worked in ICU so much. I never knew what happened to stroke people. I mean, it's like, okay, we saved your life, so now we're going to transfer you out to North Wing 7, and then you're going to go to rehab, and you think, wow, I guess they're all done. I mean, they're well. But if you really stay in close contact with people, you realize even those that look really good, that there's usually a new brain there, okay? As far as completely 100%, some of them may even get up to 98% return. There's probably little things that occur. But because of Tina, I also realized that Erlanger is on the cutting edge, that we have interventions that if we had not had them for her, this lady would be in a nursing home probably now. I mean, it's what it amounts to. So looking at the stroke risk, the biggest area of stroke risk is under cardiovascular, and I'll address a few of these, but it's these areas here that we focus on most as far as prevention. I mean, we can probably have the biggest bang for the buck if we put our money into this area of prevention. Other areas are sleep apnea, sickle cell disease. I addressed that. It's a small number of the population, but still, these sickle cell children, it allows them to live a longer life. I mean, used to a sickle cell child probably did not live past their teens, but now they can live much longer. And we'll address some of these other things, including migraine, headaches, as we go along. So hypertension is it's the leading modifiable risk for preventing stroke. And so if you're hypertensive, you have up to 6 times greater chance of having a stroke. And 40 to 90% of the patients will have hypertension before they have a stroke. Now, one of the things is the new guidelines actually really focuses on keeping your blood pressure less than 140/90. If you are a patient that's a cardiovascular patient that's already had an event like an MI, they will probably want your blood pressure even lower than 130/80. Or if you are have previous stroke patient or whatever, you may have different guidelines. But overall, the general population, if you're greater than 60 years of age, then the goal is, we'll just say if you're under 60 years of age, everybody's blood pressure should be less than 140/90. Now, these are just some of the guidelines, and if you want to look back on it, if you're working with patients, if you're an MP and actually having to prescribe, these are the committee guidelines for the medications for treating hypertension. Now, one of our big risk factors is atrial fibrillation. And if a person has atrial fib, they have a 5-fold increase of having a stroke. And as you get older, when I showed you a previous slide that showed you with age how it increases as far as the number of people that have a stroke, you realize that this is one of the big reasons, because as people get older, they begin to develop dysrhythmias, and one of the primary dysrhythmias is atrial fib. And it is responsible for 50% of embolic strokes, and these are big strokes. When you hear about large vessel strokes, then think about atrial fib, because it throws that clot out there and knocks out a large artery in the brain, and these people have big, big strokes. We can prevent a stroke by anticoagulation therapy. So we know that also aspirin or warfarin, and there is an algorithm here, and I'll go over it in a minute as far as determining who gets anticoagulant therapy. This is what we in the past have utilized to determine if the person has a dysrhythmia. A lot of times they go home with an external monitor that they keep on maybe 5 days or so and turn it back in to determine if they have a dysrhythmia. But notice here that 25% of patients that have what's called cryptogenic stroke, that's that patient you get in the unit or out on North Wing 7 or in trauma step down, and you do not know what caused their stroke, okay? Because when they come in here, we're going to really work them up to determine the cause of stroke. And 25% of those people we're not going to know after we work them up. Case in point, one of our deans at Chattanooga State was sitting in front of the secretary discussing an issue, and all of a sudden he said to her, "I cannot move my left side." So immediately she called 911. They brought him down here to Erlanger, and by the time he got here, his symptoms had resolved, okay? They still admitted him like we do with TIAs, because we want to know what caused that transient period when the brain was not getting enough oxygen. And so they kept him for like 3 days, and he was up on North Wing 7, and when the nurse went in to take off of his, just about the time she was getting ready to take off his monitor, he went into atrial fib, okay? We knew then what caused the symptom. Let's say we sent him home, okay? His chance in the next 3 days of having a stroke was like a 10% chance. And when I look at him, I just think, wow, that is such a high percentage. I mean, you know, because you would send him home on aspirin, that might have helped prevent it. But he needed to be on an anticoagulant in order to prevent a stroke. Now we have this implantable loop recorder. How many of y'all have seen one of these? Wait a minute. That is a little chip that they put in. I'll pass one around for you. They actually put it in under the chest wall, and it's very small. And just pass this around. They just make a stab here and place it in the chest wall, and it can stay in up to 3 years. They're now studying people that have intermittent atrial fib. Maybe how long does it really take for a person to have a stroke? Is it seconds? Is it running and being in atrial fib from 1 minute, 2 minutes, 5 minutes? How long does it take? What is the correlation between atrial fib and the person that actually has a stroke? So we're getting more data on this. But this way, all this information can be downloaded, just like if you had a pacemaker. They can download your the data on your pacemaker and everything. Same thing here, and tell and actually predict then and pick up on atrial fib. And it may be that they only have atrial fib once a month, and that may have been what happened to him. He had atrial fib and then again went into it. So he may, the dean may have been having this more like every 4 or 5 days. So this is your algorithm. It's called the CHADS2, DS2, whatever, here for patients with atrial fib. And it goes through and gives you a number in accordance to how high the risk is based on this data. So notice that age, anybody greater than 75 years of age gets a 2. So that puts them, just your age alone and atrial fib puts you in a high risk category. Women, a woman that has a atrial fib gets a 1. She's more likely to have a stroke than a male who has atrial fib. So then you can add all this up and determine if the person should be on an anticoagulant. So here, if they have a 0, and it would be possible, you can have atrial fib and not have any of these other risk factors. If you were a male and did not have these things here, then that would be a 0 for the male, so that would be essentially no therapy. But if you have a 1 or greater, then oral anticoagulant is the preferred method of treating these patients to prevent a stroke. Now, you can also, for those people that absolutely cannot take anticoagulants, they may put them on clopidogrel and aspirin combination. This is up to the cardiologist and the neurologist. Now, these new novel anticoagulants, they are becoming more and more favored as far as treating the patient. For one, the patient is not as high maintenance as far as checking your INR. They're not as incompatible with food and other drugs, etc. So we're seeing more and more. Which one of these do you think you see patients on apixaban or Eliquis more than the other novel drugs here? Are you seeing many patients on Xarelto? On Xarelto, are you? Now, dabigatran, interesting, Pradaxa was the first one that came out, the novel anticoagulants, they call them. And dabigatran also is going to be the first one, it looks like, to come out with an antidote, okay, to reverse bleeding. And so, anyway, it's actually been marketed right now, and I meant to have gone in and got the name of that. I saw it in a publication for the New England Journal of Medicine, just a thing that comes out with new drugs and everything. So I'll have that in there on my next presentation. So we are developing reversals or antidotes for these drugs, and that's going to make people happier about using these drugs, because as you know, with warfarin, we can reverse the bleed there. But with these drugs, we cannot. But definitely weighing the risk versus the benefit of being on an anticoagulant, unless you're just a high risk for fall and falling all over the place all the time and hitting your head, then it's usually more beneficial to be on one because to prevent those large strokes. So hypercholesterolemia, of course, one of the things that when a patient comes in with a TIA or an ischemic stroke, we make sure even before they are discharged, regardless of their cholesterol level, that they are placed on an anti-lipid drug, because the anti-inflammatory effect of these drugs help to prevent another stroke. So we like their low-down lipids or their bad cholesterol to be as low as we can get it usually, and we like to have the highly desirable higher if at all possible. And these are things that if we can get their cholesterol and their lipid panel, at a lower level, that's a factor that prevents strokes. So anyway, they don't necessarily always have a target number now, but they look at your risk factors as far as prescribing anti-cholesterol medicine or anti-lipid medicines. And these actually have indicated that more people will probably be on anti-lipid medicines because of just in general looking at your risk factors in general rather than just the numbers when you're placing a patient on a statin. Now, one of the things I look at, particularly with younger people, is a patent foramen ovale. This is where you have an opening between the right atrium of the heart and the left atrium. Note here that the prevalence is like 25%, and that's you and I mean, in this room. 25% probably have a small opening between the right and the left atrium that did not completely close at birth. For the most part, no problem, okay? In fact, it's not the problem, it's not enough of a problem that you would do an echo esophagram on everybody or a TEE. Transesophageal echocardiogram, just to pick that up. It's such a low risk factor. But you do occasionally have a young person that has a stroke, and it's because this is a larger opening than what is normal. I mean, even if you have a small opening, it's larger than usual, and they can accumulate little clots in this area. So the blood actually can go from the right atrium here into the left and go directly out into cerebral circulation then and bypass the lungs, okay? Whereas you can also have a clot, deep vein thrombosis that comes up here through the inferior or superior vena cava. Same thing, if the clot comes up through here, it can also go directly into the left atrium if that opening is large enough. So this is one of the workups they do on young people, and they do, I guess, an echo on everybody that has a stroke anyway, and what they're doing is they're looking for this problem. And another thing, whenever you're doing the echo, it's a good way of looking at congestive or heart failure, and those people with heart failure also tend to have a higher risk for stroke. So this is Fran. She was another one of our students that in her 30s that had a stroke at Chattanooga State in the last 6 years or so. And hers was, they did find that she did have this patent foramen ovale. Because of our interventions here, I can truthfully say that everybody, all the students that have had a stroke that I've worked with in the last 6 years have been really benefited from our interventions here, okay? And Fran, they did remove her clot, and so she went on and came back and finished her the nursing program, passed her boards, is working right now. I think she's at Blue Cross. So anyway, because of our interventions here and our ability to work up the patient thoroughly and everything, it's made a huge difference in these students. Now, carotid stenosis is another big area, particularly folks that are over 60 years of age. start getting plaque in their internal carotid artery. Now, there is a correlation between coronary artery disease and carotid stenosis. So always we have to keep that in mind, that those people need to be worked up and their internal carotid arteries need to be looked at if they've got coronary artery disease. As far as medically, I think they're looking more at treating this medically, if at all possible. And now we have good drugs to control hypertension, control our cholesterol, and antiplatelet medicines. That's your medical therapy that you can use for a patient like that has under 60%. Okay? Now, once you get up to 60% or greater stenosis, the discussion has to be, should we go in and actually put a stent in here or do a carotid endarterectomy, just remove the plaque out of there? So that's a discussion that has to go on between the vascular doctors, the neurologist, etc., to determine the risk and benefit there. But most of the studies shows that the carotid endarterectomy outcomes are slightly better than the stents. Okay, so you have to, it probably has more to do with who's actually doing it, what doctor is doing it. Hypercoagulopathy. One of the things as far as Tina that was concerned, the first student that I showed you all, why did she have this stroke? Well, Tina told me the semester before she had her stroke that she had had a pulmonary embolus and she was on Coumadin, okay? So she had a pulmonary embolus and you're on Coumadin. Sounds like a plan to me, right? But at some point her doctor took her off of the warfarin because he thought it was related probably to the hypercoagulopathy state she had been in after she had a hysterectomy, okay? So it was discontinued, and a few months later, she had this stroke. So she probably has a coagulopathy problem, but you can do it. Sometimes the factors do not show up with these folks. You can't really determine if they are, if they're a Leiden mutation, factor 5. That's one of the more common types of hypercoagulopathy, but you can do a workup, but you do not always find the clotting problem. Sickle cell disease, I've already talked about that. And one of the things, oral contraceptives. If you have a first or even a second degree relative that's had a problem with coagulopathy, they've had blood clots formed and everything, say it was your mom or your dad or your sister, and you are on oral contraceptives. Well, one of the things you have to realize that you may have the coagulopathy gene too. So those two things together are going to make you at a higher risk for a stroke. Oral contraceptives, I mean, there's still a debate on how risky are they, okay? But billions of people take oral contraceptives. But the big thing is, and they're looking at, I guess some of y'all have been on Yaz or Yasmin. These are the third and fourth generations of oral contraceptives. And they tend to be, even though they're lower estrogen, they tend to have shown up to be present in more strokes than the older ones, actually. So, but then again, does the person smoke and take a contraceptives? Are they hypertensive and take contraceptives? Do they have this coagulopathy problem? Are they very obese? I mean, there's different things that go along, so you have to weigh the risk of pregnancy, the risk of having a baby and even maybe having a stroke then, versus the risk of taking a contraceptive. Okay, smoking, we know that's up there at the top as far as causing stroke, so we'll move on from there. Diabetes is another thing that is a high level, and it's, I guess you could probably look at this and look at hypertension. It'd be very similar, where you have people that are, just a few people maybe are unaware of having hypertension or diabetes, but a lot of people have high glucose, but they They're aware of it. They're not treated. They just kind of ignore it. Some are treated and controlled, and then there's a large number that are treated but are uncontrolled. And this does not mean that you're poor, outcast, or have no access to health care system. Very educated people do not take care of their glucose problem, okay? Now, this is just some recommendations as far as blood pressure and your diabetic, etc., and I'm going to move on with that. This is just shows the BMI overweight folks here, and there is a correlation, of course, between obesity, high blood pressure, stroke, etc. And the thing about it is we don't tend to be getting that much better at decreasing weight. I don't know exactly what can be done there. We need to do more with our health habits, but that's kind of an individualized thing, and you just cannot control people in those areas. But this is us here, and as you can see, there are some. Montana up here looks pretty good. All right, so obesity, it really has more to do with where your obesity is. Is it the waistline? That's going to predispose you to more cardiovascular risk. And definitely weight reduction is reasonable, but if you really look at weight reduction as preventing a stroke per se, the evidence is not real strong. I mean, there's just not been that much data collected on that. Now, this is what is the tsunami, though, the big problem that's going to occur in the future, because if you look at the overweight children and the percentage of children that are overweight here, and this has not gone down. I mean, I agree that this is data from 2010, and actually this was it's still presented as data that was collected up to 2006. But what we're looking at now, it has not decreased as far as the number of overweight children, so we have a lot to do there. 1 out of 5 children have abnormal lipids. Now, this is scary, is it not? That these children that have abnormal lipids in 20 years from now, they're going to maybe be in their 30s, and these children are now going to be having strokes at a very early age. Migraine, people ask me about this. The correlation with stroke is the migraine with aura. And what do you do about it? Well, if you smoke, you should quit smoking if you have migraine with aura. It's sort of like the contraceptives. What other risk factors do you have in addition to the migraine with aura? If you can abort and really work and to abort your migraines and initiate your therapy there, that would be great. But if you continue to have migraine with aura, then any other risk factors, you should really work to minimize those. Sleep disorder breathing or sleep apnea, anytime we do a education in the community, we always have a pulmonologist there that talks about sleep apnea. And there is a lot of Americans that have sleep apnea, and that is another thing to address. Alcohol, the correlation there is with people that drink excessively, any more than 1 drink per day for women or 2 drinks per men, they have a higher stroke risk there. And we know that there is a correlation. These people that you get in, and I know there was some guy up in MSICU one day, or I think it was up there, that I went in to see. And, I mean, this guy drank, 12 beers a day or whatever, and then he had a stroke. The big other risk factor he had was his blood pressure. There's a huge correlation with excessive drinking and alcohol and high blood pressure. And so this is probably, and also the risk for atrial fib. So sometimes you might see a 30-year-old that's been drinking for 15 years, say, 2 6-packs a day or whatever. Sometimes people even drink more than that, I think, or a lot of vodka or, heavy metal alcohol, I call it, that are going to have atrial fib at a young age. There is a correlation there. Now, inflammation, infection, as the years go by, we will be finding out more and more that stroke is probably related to inflammation and infection too, but we don't have any strong evidence at this point. Access to medications. Do you all think that patients are, thank you, that they're getting better health care? Raise your hand if you think patients today in 2015 have better health care than they do 2 years ago. Y'all are just not going to help me with that, are you? I don't know. Maybe people are coming in to the hospital more. Maybe that's why we're having more stroke patients. I don't know. You also have, like, when they send a patient home on Eliquis or one of these novel anticoagulant drugs, sometimes they can't pay for their copay. I mean, there's still issues with medications. So just understand that you'll probably, still see patients that because of not taking their medications, maybe because of their the economic aspect, they have had a stroke. Disparity of care, I think I've already addressed that somewhat, but as far as the disparity of care with minorities, the African American in particular, that population within the Chattanooga area, this is another area that we need to address. So are we making progress? Some people, I guess, in some areas, people are somewhat healthier. I think the word is out about stroke, and I think we're getting more people here that are recognizing symptoms and coming on in. Stroke is not selective. Anyone can have a stroke. Famous people, just the common man, whatever, these people have strokes. And has anybody heard anything about Randy Travis? You know, he had a stroke a couple years ago. Have you seen him perform in the last 2 or 3 years? I haven't either. He had an intracerebral bleed, I believe. Okay, questions? Going once? All right, we'll move on and do transient ischemic attack, and then I want y'all to take a 5-minute break and just walk around and get your blood circulating in your brain. Now, this is an area that's huge. I'm looking around this audience, and I'm probably not seeing anybody in here that has worked in the health as far as at Erlanger, maybe for, like me, 20 years ago. So 10 to 20 years ago, if you came in with a TIA, what do you think would have happened to you? You would have been, they might let you see you had a minor symptom, or it was symptoms that were getting better, and you'd say, okay, just sit over there for a while and we'll see how you do, and then you get sent home. That was it. So now we know that this is a big area of the number of patients that we saw last year. I don't know exactly how many were TIAs, but they were not full-blown strokes. They came in here, they were admitted, and then kept and had a workup to determine or try to find out the culprit, what was causing this stroke. And so, anyway, that would have been your secondary prevention after they've had the symptoms. Of course, early on, primary prevention is just teaching healthy habits, keeping your blood pressure under control, etc., in order to even prevent the initial TIA. So what is a TIA? The classic would say it was symptoms that lasted for less than 24 hours. But now we don't really have a time frame on it. You have the symptoms, and it's transient, okay? And it can be focal, brain, spinal cord, or retina. Again, just like we said, it's central nervous system, and similar to the same thing as a stroke, except when you do the workup and have like a diffuse weighted imaging on an MRI, you see nothing, okay? So the dean I was talking about had the symptoms. By the time he got here, his symptoms had gone away. But when he had the MRI done, he did not have any indication that he had actually had a stroke. So you may have a patient that comes in here that's treated for symptoms of a stroke, and then they have a MRI and it's completely negative, okay? So you can't always distinguish between are they really having a stroke or is it transient when they get here, so they very well could have therapy and have TPA. Now, as far as retrieval of a clot, they're going to, if they do a CTA or whatever, they would be able to actually see it at that point. So most of these symptoms are going to resolve in 1 to 2 hours. So we work the patient up. We initially do a CT just to see if there's anything, mainly just to rule out a bleed. And then we want everyone to have an MRI. And this gets to be really a big issue, doesn't it, Adrika? Getting all those MRIs done before the patient is discharged. Most of you all that are in ICU, you don't have to deal with that. But that's one of the things that causes us to backlog and not be able to get patients out of here, is we want that MRI because it's really the gold standard for determining exactly where the stroke is. We do carotid imaging, echo, transesophageal. All these things are done to do a workup to try to find out what the cause is. So here you have a lady that's 75 years old. She's 5'5", weighs 160 pounds. She's a diabetic. So right there, she's a little bit maybe overweight, not extreme so, but being a diabetic predisposes her to cardiovascular problems. She had gone to her PCP because the day before she had had 30 minutes of not being able to speak. Her vital signs, if you look at this, you'll see her blood pressure is high, so that would be a risk factor for her. She has her low-down lipids, her bad lipids are 160, and we know that for anybody across the board, we want that to be less than 130. Her highly desirable lipids are 30, and so we would like for the rotor-rooter type of cholesterol or lipid to be increased up to at least 45. Her triglycerides are elevated too. They should be under 150. And her blood glucose doesn't look too good. It's fasting of 150. And we know normal blood glucose is 60 to 100 or 70 to 100. So you've got someone that's got several factors there. But when she was evaluated, her NIH stroke scale was normal. So what can we do? Modify for her? Her blood pressure, her cholesterol, and her blood glucose. Now, this just goes through an algorithm of looking at the difference called the ABCD2. And if y'all like to look things up, I think it's a good thing to have on your app. You can pull it up on your app, put it in for the web, and actually it's MD Calc, and you can get all kinds of good information and different algorithms for predicting things. So if you want to tag this page, please do. But you put the different data in as far as how long the symptoms lasted for the TIA, how severe the symptoms were. You put all this in, and then you can predict how high risk the person is for having a stroke. And this patient, actually, her age, blood pressure, the duration of her symptoms, her being a diabetic, and her clinical presentation gave her a strong risk for a stroke risk that was very high. So this is the take-home here. This is why we need to get the word out. Even if you have the symptom and it goes away, only lasted 30 minutes, need to be worked up because 10% of those people have a stroke in 2 days, 14% in 30, and if you just remember, 16% in 90 days. That is huge. So we can prevent a lot of strokes just by getting the word out and educating people on this. So how do we treat a TIA? Let's say that it was cryptogenic. We could not figure out what the cause was initially. Well, the minimum amount we can do, at least, is to put them on a aspirin, okay? You say, well, should you be on a whole aspirin or 80 milligrams or whatever? The studies have studied every concentration of aspirin, and they're all pretty much, outcomes are pretty much the same. So aspirin is actually shown to be as effective, if not more effective, than these other drugs here. If it's cardioembolic, then you want them on a anticoagulant. I just highlighted this because it was our first novel anticoagulant. So the patient needs, if it's a cardioembolic, they should be on an anticoagulant. All right, so this completes this section. Any comments or questions here? Please take a 10-minute break.